My name's Heidi Kraft. I'm a clinical psychologist, and I spent 10 years in the Navy as a flight psychologist and clinical psychologist, and spent most of 2004, along with you, in Western Iraq with a Marine Corps surgical company. Obviously a long 7 months, a lot of casualties, a long haul for a lot of us, but as much as it was the worst 7 months of my life, it also turned out to be the best in many ways, and I wouldn't trade it for anything. It changed my entire career path. It led me to be a totally different kind of psychologist and focus almost exclusively now on combat trauma and still taking care of Marines, which I guess I've always done.
That's great. That's great. So you actually continued on with it after that?
I did. I'm a Navy contractor now, and part of my job allows me to continue to take care of active duty Marines. So it's still the best part of my job. February of 2004 is when our group headed over there, and obviously the very beginning of the counterinsurgency, and at a time when I think we were still learning a lot about what we were going to be seeing and what to expect. As medical providers, we prepared for the deployment truly and fully expecting to be providing humanitarian assistance for Iraqi women and children. We just had no idea what those 7 months would hold and how, in fact, dynamic and chaotic and traumatic a 7 months it would be. So we were situated about halfway between Fallujah and the Syrian border, and so our surgical company ended up taking a fair amount of the casualties that happened sort of in a lot of those areas in western Iraq and Al-Anbar province, shared the load with our sister company in Fallujah. But it was, like I said, a dynamic time, difficult time, I think, for all of us as we figured out what we were going to be facing. Certainly for the Marines that we ended up taking care of, it was a very high period of time for casualties, for both Marines killed and wounded in action. And our surgical company took care of a lot of your brothers and sisters. Of course, we had no idea how long this war would last. I think back in 2004, all of us had the same hopes, and that is that it would be as short as possible. And so I don't suppose there was any way I could have really imagined that Afghanistan would ramp up, that Iraq would go on as long as it has, that so many of my patients would have deployed 3, 4, 5 times by the time I'm doing this interview in 2011. So no, there's no way I could have foreseen what we face today with regard to the marathon that is combat stress injuries and what a long haul this is going to be for our warriors as we move forward. That said, what came through my doors during those 7 months, and we were busy. I was there with one psychiatrist partner and 2 psychiatric technicians, and we were the combat stress platoon. And we were busy. We saw patients all day, every day for 7 months. Into the night, we were that busy. So it was a good thing in many ways that the Marines trusted us enough to send us their people, that people walked in, that they were treated in the wake of bad things happening and were feeling strong enough to stay there. Everybody wanted to stay. No one wanted to be medevaced. They wanted to stay with their units. They wanted to stay in the fight. It was across the board. That was my experience. So knowing that that was my job was to try to keep people functional, keep them with their units, keep them in the fight. Still, the things they brought to me were, they took me out at the knees. You know, it was so much trauma and so much loss in such a short amount of time. And people were functioning okay because they had to. Mm-hmm. You know, I think that's where combat trauma is different than other kinds of trauma. Mm-hmm. Those that suffer trauma in combat don't have the ability to just stop, just take a break and process it. It's not the way it goes. You put your blinders on and you stay in the fight. That's exactly what my patients did. So I had a slight, I think, feeling at that point about the extent to which these traumas would haunt these people. I had no idea some of these people would go back 4 more times. Post-traumatic stress disorder in and of itself is in fact a psychiatric diagnosis. We classify it as an anxiety disorder. So it is based in anxiety rather than other types of mental symptom clusters. But the key thing about PTSD that makes it different than any other psychiatric diagnosis is that it has to be based in a trauma, at least one trauma. What we know about combat is it's often years and years of cumulative trauma, but it has to be based in something the person's lived through that is really horrible, really awful, really, really something out of the realm of a normal human experience, which everyone who's been to combat knows that's what I'm defining right there. But some of these experiences stay with people, and they're difficult to process, and this is how the mind is doing it. It's working through these various symptoms. It's showing you symptoms, telling you that it's time to get help. That's what all these symptoms are saying. What it is not is a sign that a person is crazy. See, we take the word crazy very seriously, but crazy to me, as a shrink, means that a person has lost touch with reality, that a person doesn't know what's real and unreal. And while folks with serious PTSD have very realistic nightmares that probably border on that moment, it's fleeting, and they are serving a purpose, these nightmares.
Right.
They're trying to tell you something, which is, okay, it's time to get help. Same with the intrusive thoughts, same with the paranoia. All those pieces of the disorder are symptoms. Just like the swollen ankle, the symptoms are trying to tell the person something.
Right.
So it is a psychiatric diagnosis. When you get to the point when you get that diagnosis is when it's really interfering with your life, starting to interfere with work, with relationships, with a person's ability to live normally. And that's when help is needed, and help is needed immediately. It's time to use one of these evidence-based treatments and get those symptoms under control. One of the problems we've had for the last 7 years is that we've focused so much on what we call PTSD, when in fact PTSD as a diagnosis is at one end of a very big spectrum. What we know is that normal people suffer normal injuries under stressful situations. These can be physical or mental or emotional, and injuries don't discriminate. And this is where the Navy and Marine Corps actually really has embraced this idea that normal people in a traumatic or extraordinarily stressful situation can be injured by that situation. So when I get the chance to speak to groups of people, I'll ask them, what do you do when you sprain your ankle, when you suffer a bad sprain? What does your body tell you? How do you know it's injured? And everybody knows those answers. You know, they all raise their hands and they go through all the symptoms. They can list them off. It's swollen, it hurts, it causes us to be, not able to run like we used to be. Okay, fair enough. Now, what do you need to do? Immediately after that injury, what do you need to do in order to mitigate that problem, in order to hopefully cause as little down the road problems as you can? And everybody knows those answers. They're very quick to spout them off. Ice, rest, maybe elevation, maybe wrap it. Go to mom, exactly. Vitamin M, right? Get that Motrin on board. Everybody knows exactly what to do. And then I say, okay, well, what if you don't do it? What if you don't do all those things? What if you ignore that ankle, keep it in the boot, laced up, and keep running on it, keep walking on it, keep doing your long hikes with all that crazy weight that you guys wear? What's going to happen to that ankle?
Way worse.
They all know that. You know that. Everyone knows that. It's going to get worse. It will slowly continue to get worse to the point then someday you have to take the boot off, right? You have to. You got to take a shower.
That's right.
And then it puffs up like a blowfish. Then you can't hide it from the corpsman anymore. And then suddenly now you've got a referral to PT. In PT, that physical therapist is probably going to give you exercises, strengthening, maybe ultrasound, maybe traction, maybe soft tissue kind of work. There'll be some work you have to do at home. And I say to everybody, is it possible that if you do everything that physical therapist tells you to do, that the ankle could end up being better, stronger, more flexible, less likely to be injured in the future? And they all have to admit that that's possible.
Right.
Not just possible, but probable. And then I hit them with it, right? It's exactly the same thing. We are talking about the same thing. And this is where I think across multiple years of culture, our culture, a culture that for a long, long time had no tolerance for anything other than emotional perfection. This culture set us up because the men and women who have come before us in the military, they didn't have the chance to believe that. They didn't have the chance for anyone to tell them that these injuries are the same, that there's a way to take care of them in the acute sense. But if we can't, if we don't, if the situation won't let us, or if we're just stubborn enough to not do it, treatment works. And not only does treatment work, we can emerge from it better.
Absolutely.
So I think that's really important for people to understand. Injuries are injuries are injuries, and treatment for combat stress injuries works. And people can actually experience growth after trauma. They can be better. I think that's probably the most important thing for anyone to understand. If they understand that, a big part of the stigma we've faced for all these years is gone.
Yeah.
So at the end of the sort of long continuum of combat stress injuries would be what we call post-traumatic stress disorder. And this is the psychiatric diagnosis, the diagnosis that's made by a mental health provider. People who fit that diagnosis criteria have lived through a trauma, as we talked about, something horrible or terrible or causing intense grief or fear. That's the primary thing that sort of separates PTSD from everything else in the mental health realm. But then they have some sort of interesting clusters of symptoms. And one is avoidance. Heidi Kraft's opinion, this is the biggest problem in PTSD. We avoid things that we don't like thinking about or don't like remembering. And the longer we avoid them, the more emotionally charged they become, the more they put their hands around our necks. And so with PTSD, people avoid memories. They avoid thinking about the trauma. They avoid things that remind them about the trauma, people that remind them about the trauma. Anything that's connected to it, it's painful, they don't want to go there, and they avoid it. It's normal human experience to do this. But in the case of PTSD, it gets worse and worse and worse. It starts to build on itself to the point where it becomes a problem in and of itself because they start avoiding life. Many of your colleagues that you know probably stay away from movie theaters. They stay away from crowded restaurants, places where it's loud. They need to sit with their back to the wall and be able to face the exit in a restaurant or they're not going in. You know, this is where that avoidance of situations starts to really interfere. Other symptoms people may have is this, what we call the re-experiencing cluster, and this is where the nightmares and the intrusive thoughts or images start kind of popping in uninvited. Again, these are symptoms trying to tell the person, it's time you remembered this. It's time you worked through this and let it go. That's what those nightmares are about. But obviously they're extremely distressing to people. They're horrible, and they're, in fact, many times what brings a person in is the sleep disturbance and nightmares. So that re-experiencing, that's those thoughts that enter your head and kind of cause the person the really stereotypical flashbacks or some of what you may have heard with PTSD. This is the thoughts that kind of float in uninvited, or the nightmares. And then we sort of have this other cluster of symptoms where a person feels very anxious, very paranoid, very unsafe, hypervigilant, kind of looking around all the time. This is the exaggerated startle response, where if a car backfires behind you, you might hit the deck. I know I went to a Chargers game right when I got home from Iraq, and they fire a cannon when they score. I think I knew that somewhere in my long-term memory, but I hit the deck. Didn't know it was coming, and it was very embarrassing. But I'm sure I'm not the only one. I'm sure there's a whole group of us that could be the, I hit the deck at a Chargers game, club, because it probably has affected a lot of people. So this is this sort of increased arousal, the physiologic sense of stress and trauma kind of brings in its own group of symptoms, and they cause the person to be really agitated and angry and kind of overreacting. The primary reason that Marines and sailors have come to my care has been anger. That's the sort of across the board reason they come, because the anger is so out of proportion of what they've ever experienced before. They're totally intolerant of their children's noise.
Right.
They're intolerant of being touched wrong or if they're not expecting it. They are angry at nothing, and they are flying off the handle at nothing. It's the transition from worlds that are so different.
Right.
So in combat, everything's black and white. There's no gray area,
Right.
ever, about anything.
Right.
Your job is very clear. You know exactly what the consequences are if you don't do the job correctly. You count on people completely, right? Then you get home and none of those things are really true. In fact, they're not true at all. It's all gray.
Yeah.
In America, it's all gray. And I think that's a major problem for people as they transition, is finding that being able to live with the gray,
Yeah.
with people that aren't familiar with that world,
Yeah.
it's very, very frustrating. And so the intolerance for that goes through the roof. People that I hear this a lot, that people that are upset about problems in their lives that are so inconsequential compared to life and death,
Right.
very difficult to reconcile that. And so these are a lot of the things people bring back from combat, and most of us would say, oh yeah, I've heard that before. But yeah, I think the anger is the primary thing that will bring people into treatment because it's really affecting their families. Another big one is self-medicating with alcohol.
Right.
It tends to make them feel a little calmer,
Right.
so it helps in the very acute sense, and then very quickly that is a bad idea. It doesn't work for anything. It makes you more aggressive and more angry, and it decreases REM sleep, so you start having more problems sleeping, even though you think you're using it to sleep. So it just, all in all, it backfires across the board. But obviously can lead to a lot of problems and lead people to come for help. I think first and foremost that it works. Secondly, I tell, whenever I get a chance to talk to staff NCOs or officers of any branch, I want them to know that it's relatively short term. That for people with sort of uncomplicated combat stress injuries or moderate PTSD, we have treatments that are very succinct. They get to the point. They don't spend years and years on a couch. They actually get to the point. They work through the trauma, and the person moves through the trauma and hopefully gets those symptoms to the point where he or she can get on with life.
So it's absolutely treatable. It's something that you can move on with life.
It is absolutely treatable.
That's great.
Most definitely. The times when it gets complicated is when there's other things involved. When we have, for instance, alcohol dependence, drug dependence, other maybe predisposing depression, other things. It gets more complicated, and it's obviously a little longer to deal with that. But I think when you're talking about pure trauma and the reaction to trauma, a normal person under an extraordinary circumstance, this is very easily treatable. As a person who has served with the Marines almost my entire career, is married to a Marine, some of my best friends are Marines, but was a sailor for 10 years as well, and I feel really connected to both of these worlds. Even now that I'm a civilian, they'll always be my worlds, and it continues to break my heart to see people suffering for such a long time before they finally decide enough is enough. So I think what I have hoped that people would hear whenever I get the chance to speak is that not only is treatment successful, but it can actually lead to an entire different perspective in life, a growth that it's entirely possible you didn't know you had in you. So many of my patients and myself, we've become different people through this journey, and those people are better. They may have suffered, but that's trauma. Trauma causes suffering. Combat has always caused trauma. There's no way around this. So what I always tell people is, you will be changed. I get a lot of spouses asking me, does he have to be changed? I want the same guy back. And I always tell them, that same guy's not coming back. There's no chance. We will all be changed, and we know that. Those of us that have been there know that. But what I think people don't realize is that that changed person can be better. Not only can, but will, if they give themselves the chance. If they come forward and ask for the help they need, It's not only possible, I've seen it happen again and again and again. It's probable, it's likely, because these are strong people. These are strong people who were in a bad situation, and they're motivated about everything else. So I always sort of try to say it as much as anyone will listen. Be motivated about this, because it's very possible you'll end up better out of all this.